Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello, my mechanically minded friends. I am the Millennial Mechanical Therapist, and today we're going to talk about derangements and do you always find them? Because everyone seems to think that MDT is all about derangements. Now, derangements, or an internal disruption of the articular surface, the newer-ish definition. The disc model is what it's really been related to in the spine for a long time, although, sidebar, Robin McKenzie originally did not want it so related upon the spine or the disc model, but it was kind of a necessary thing at the time, something that everyone could relate to, something that at the Institute, when he was forming it, really pushed him towards grasping. At least that's what I've heard from other diplomats. There may be different stories out there. Please don't take that as God's word, just some information. But, more and more than not, when I talk to people about McKenzie, MDT, we hear these things on the Facebook chat lines and the group messages is, you're just looking for a derangement. Now, jokingly, a lot of people who practice MDT frequently and throughout their assessment skills will really, joke around and say, well, I'm hunting for a derangement. I'm trying to see if this is a derangement. And I think, it's kind of brought on a stigma to the entire assessment form, the entire assessment skill set on itself. Yes. Do you hope to find a derangement? Yes. Why? Because derangements in their nature are rapidly reversible situations. And wouldn't you want to be someone who helps someone get better in 4 visits with only 1 exercise and some education? Doesn't that seem like a good thing, is to help them that quickly? And you're hoping for that because it not only does it help, or not only is it good for your business, for your brand, for you as a therapist, but that individual could have little to no disability within a week or 2. And in my mind, yes, I want to find that. But that's not the goal of the assessment. That's not the goal of MDT. The goal of MDT isn't to force everyone to be a derangement and get them out of your clinic. The goal of MDT is to assess the patient in a non-pathoanatomical way, classify them if you can, yes, if they're a derangement, or into a dysfunction classification, in postural syndrome classification, in the other classification syndrome, which the Institute itself is working diligently on now, to improve the way that we should, as mechanically minded therapists, attack that. And if you're going or know about the conference in, I believe it's Orlando, upcoming in August, that's the whole goal of the conference, is talk about the newer stuff coming out by clinicians and researchers who are really trying to break ground in how mechanically minded or McKenzie minded therapists should attack the other subgroups. No. It isn't just about finding derangements. Do you hope to find a derangement? Yes, but that's not the goal. And I'm going to give you a case today about a woman who I recently evaluated and have been treating for about a week and a half, 2 weeks, who wasn't a derangement. And again, you've heard me say this before, everyone deserves the evaluation, and nothing that comes out of the evaluation can be a loss, because even if they're not a derangement, that doesn't mean you lose. That just means they're not a derangement. And you have to know how to attack those problems and how to educate the individual on how they should attack the problem. And that's really where the beauty, I think, of this whole thing comes from is, yes, if they're a derangement, man, do you get to look good? Does that person get to get out quickly and have a wonderful experience? Yes. But if they're not, we have a whole bunch more skill set to offer. We have education. We have posture. We have the traffic light system, which a lot of us talk about frequently, on how to attack dysfunctions and things like that. We have so much to bring to the table. If you want to use manual skills, use your manual skills. It doesn't matter. Just the fact that you can say that they're not this or that, that's beautiful. So to get off my high horse and my podium, let's talk about the patient case at hand. So I had an older woman come into me in her 70s, late 70s, with a long history of neck pain. When she described her history of neck pain to me, she verbally and visually described an acute wry neck deformity 50-odd years ago that was managed through rest, heat, and a chiropractor who gently brought her back into neutral, and then I think he even brought her into an overcorrection. So obviously he was that gentleman or female, I have no idea who that was. That chiropractor was good enough to understand what they needed to do at that point in time. But since then, she's had a long-standing history of episodic neck pain and loss of range of motion of her neck. And she kind of described to me that she really just, if it hurt, she didn't do it. Well, she's had neck pain and also intermittent headaches for 50-odd years. She's coming to me because, her physician wanted her to see a physical therapist. She's had some newer headache symptoms that have actually drifted into the eye in the past couple months. That's really the only thing that's changing, but really she says her neck is an unchanging situation. The only things that seem to really set her off are sitting when she's reading, turning her head from side to side, and then rising from a lying down position. But nothing really makes it better besides just heat and lying down. And the things that make it worse consistently make it worse every single time. There was sometimes nothing variable in her history. So, take that for what it is. No real red flags besides her age. So we went from there. The objective assessment, reflexes looked fine, strength looked fine for a 77-year-old female. Didn't see anything cranial nerve-wise. And a gross loss of cervical range of motion, like huge. Probably the biggest gross loss of range of motion I've ever seen in my career. Literally could only move a couple degrees in each direction. She had a little bit more in the sagittal plane than she did in coronal and transverse, but not by much in any means necessary. However you're measuring, huge loss of range of motion. Posture didn't influence her at all. So we went into the repeated movement testing. And if you have taken an MDT course, and when they go through, this is a little side note, but there's meaning to this, and you've taken the MDT courses or a course, and they go through what a dysfunction is and how to find a dysfunction and what a dysfunction will look like upon the assessment. The dysfunction by nature, you'll consistently not have pain at rest and have a produce no worse outcome with movement. So a movement produces the pain. Once they come back to neutral, they're no worse for it. And that's classic dysfunction. And that you'll have no huge changes in range of motion. You could have a slightly increase in pain at rest if you do a lot of movements, but within about 5 to 10 minutes, that will go right away. That's a dysfunction. And this woman was textbook dysfunction. Retraction produced no worse. Protraction produced no worse. Flexion produced no worse. Extension produced no worse. And, I killed this woman's neck. She probably did 40, 50, 60 repetitions in each direction. Produced no worse. And by the way, I think I missed saying this. Her symptoms were a little bit of something in her eye and central symmetrical, just neck pain, nothing even into the upper trapezius areas. So, in my mind, there was no reason to deviate into unilateral movements, which I did, produce no worse. So I sent the woman home with flexion for 2 reasons. I figured if it's going to expose a derangement, this is the movement that's going to do it. Or she's going to come back and be exactly the same. I really thought, I've never seen something so blatantly in my face like this. I really had a good grasp that this was a dysfunction. I thought she was, I've never had a multi-directional dysfunction in the neck, which is just, a a soft tissue dysfunction in all directions. And this I really believe was going to be my first. And I was proven right. She went home. She did 10 to 15 flexions of her neck every hour, like I asked. It was no worse. She actually said that there was a little bit of alleviating of the headache, probably because it's due to the dysfunction, and we're just slowly going into that. And she, I continued to educate her. We talked about what the dysfunction means, what it is, why she probably has this dysfunction, and that no, she's not going to see drastic changes in 2 weeks, but over a course of 4 to 8 weeks, she'll start, within about 4 weeks, she'll start seeing some good changes in range of motion. Hopefully within 8 weeks or so, she'll see greater changes in range of motion. And as long as she keeps going, we'll add more directions as we go to get more of the movements in. And she was happy with it. I mean, I think, she really seemed to accept what it was. And with the education, she was excited because at least she had knowledge of what it was, that there was at least a plan of attack, that it wasn't just me passing her off to another physician. So, although it wasn't the greatest hurrah, we changed you and your life is better now, this goes to show that not everyone is a derangement. Even if you want them to be derangements, they're not. But that's not the goal of the assessment. The goal is to classify. And I classified her correctly, pat on my back, but I classified her correctly, and I was able to give her education on what to do, on how to do it, and where to go from there. So, beautiful. And I'm not going to waste her time. Yes, could I have her come in a couple times a week and maybe apply heat to it, manually stretch her? I could. And I even gave her the option, because sometimes for people, I like to see them at least a little bit in the beginning to make sure I'm not missing anything. I gave her the option, but she was happy with following up with me every other week or so, kicking butt on her exercises and going from there. Great. She's probably going to do just fine within the next couple of weeks or so, and while we maximize how much of that dysfunction we can truly remodel. Who knows? I mean, we have 50 years of neck history to deal with. Who knows how much of that neck we can truly remodel? But at least we have the education, and we know it's nothing else. So, again, this is why everyone deserves an evaluation. Again, the evaluation, the assessment is not meant to solely hunt down derangements, although that's what we like to see. It's meant to classify your patients and empower your patients. And no matter how you're treating patients out there, whether it's manually based with this technique, with that technique, with the MDT assessment, my goal, our goal at Millennial Mechanical Therapists is not to bring you over to our side. It's to show you our journey in becoming mechanical therapists and trying to be the best therapist that we can using the assessment, because that's what we've both found, Clay and I have found, to give us the most power to empower our patients. And if you're empowering your patients a different way, great. But truly, that is what we need to be as a profession. We need to empower them, and we need to provide our skill set of assessing them and truly letting them know if they can benefit from us or not just keeping them because we want our numbers high. Again, I'm getting off the podium. I think everyone gets the drift of this message today. Sorry, I kept this one a little bit longer than I normally do. See you next time. Follow us on Facebook and get us on our website. You know where we are. Please leave any messages, any questions or comments. We'd love to hear from you, and anything that you're finding out there or how you're finding things, or even critiques on what we're doing. We'd love to hear it. We're all just getting better together. I'm glad. I hope you're getting enjoyment and some knowledge out of these videos. And we'd love to hear feedback. Like I always say, move your patients early, move them often, and move them to end range, my friends, because that's where the magic happens. Until next time, I am the Millennial Mechanical Therapist.